Good evening, friends. Last day we discussed regarding that neurological examination and then important reflexes and then in that time no we discussed little regarding the increase the ICP and then how to manage everything little bit we discussed today. We will deal with the external ventricular drain care and then what is the nurses aspect, what is the nurses role, how to monitor the ICP. Today we will discuss. And then myself, Mr. Murugesh, I am working in King Fahd Hospital. Let's begin our study. See, this is our this one brain and all. See, we heard regarding that Cushing's triad. It means it's in three symptoms. We can in case of increased ICP, we can see this one: increased systolic BP, and then decreased pulse rate, and then decreased respiration. We can see in these cases of increased ICP. We will begin our discussion. See, this is the whatever our brain. See, I will in briefly we will discuss regarding the brain and all. What is the anatomy and physiology of the brain? See, this is our normal brain. See, this. See, this is the brain. It is our ventricles, and then as we know, there are four ventricles. Means first and second, and then third, fourth, like that ventricles are there. See, usually that first and second, no, they will secrete CSF. Even third and fourth also they will secrete, but comparing to this, and then first and second, they are most secreting this one CSF and all through foramina mantra. It will enter to third this one third ventricle, again third ventricle to again it will goes to fourth ventricle, and then in that fourth ventricle no it will goes to subarachnoid places, and then it will circulate all over the brain, and then like that it will maintain the homeostasis, whatever brain whatever cerebral perfusion, everything it will be maintained. Even whatever reabsorption, usually CSF around in 500 to 550 ml it will be there. And then usually if it is goes more means if it is in case if it is hypersecretion because of hematoma or whatever, some interventricular tumors, and then some injury, if it is secretes more, and then if it is depletion of secretion or increasing increased secretion, it will cause decreased or increased ICP. It is the thing. See, this is the ICP manometer we are using, whatever our drain correction, EVD, everything is there. We will discuss. This is the one main thing. Lateral ventricles, it is the main things. They all secrete this one whatever or CSF and all everything. Usually CSF no, it will reabsorb most of the thing. That's why this EVD insertion means nothing but see here you can see EVD procedure. It's not a big thing. It's a small thing. See, you can see in this you can see it is an usually in emergency cases and all in ER, and then some ICUs means well equipped ICU also they will do in the bedside and all. See, it means using small scalpel they will use, very small scalpel, and then with a single, usually they will use means right side only they will prefer, because these ventricles are most means little bit near to the right part of the brain. That's why usually right portion they will make. Even left side also they are doing, but most of the neurosurgeons and all they will prefer to do it in right side. See, it means they will take one small scalpel and then very small, then they will do small cutting, and then they will insert one catheter. See, this is the catheter. You can see it's visible here. You can see this is the catheter, and then they will introduce, and then it will enter up to that magnum. See, here it's entered. This you can see the line. Here there is line. I think it's small. This one is there. See, here it's they inserted, and then it's like butterfly, like that suture will be there. Here it will goes to here. Here there is some two stop cocks. It means for sampling their purpose. This is the patient portion. This one we are not supposed to touch, because we need to maintain maximum this one sterility in this thing and all. Here usually extra everything it will be handled by the neurosurgeon. Whatever our nurses know, we as a trained nurses and all, we can do the sampling whatever it is. See, this is the one. See, with this, and then this is it will goes to here. Usually our we have, if it is we have monitor, it will be connected to the cardiac monitor, like that they will assess the ICP pressure and all. Here is this is the transducer, and then here it is the this is the drain chamber, that is it one they will say chamber. Here it is hourly, it is draining into this chamber. Hour that means hourly we need to empty. This is the collection bag. This is the briefly means everything, it's ever set up, everything it will be done by the neurosurgeon. As a nurses we should assess, we should monitor the hourly EVD output, everything we should do. That is the thing, nothing, it's simple thing only. See, it means I will say you the definition. An external ventricular drainage, and then another name for EVD is ICP monitor. It's a temporary method of draining cerebrospinal fluid from the ventricular system of the brain when the normal flow of CSF is altered. In some cases because of interventricular hematoma, and then because of hydrocephalus, and then because of some trauma, injury, and then brain tumor, whatever. In these cases, no, it will be altered, whether it will be more secretion, hyper secretion of CSF. In that cases, no, usually they will prefer to go for EVD. This is the thing. And then usually that normal ICP is 0 to 15 mmHg, means 0 to 15 millimeter of mercury. It is the normal pressure of ICP. Usually this whatever it is there, no, this is the cranium. 80% of the pressure it will be produced by the this one cranium. Suppose if there is injury or means injury or skull injury and all, no, usually because of skull injury it will again increases the ICP. That is the one thing. Even 10% of blood, suppose because of hypertension and all, no, because of hypertension also nowadays we are seeing so many cases. Because of hypertension and all, patient ICP will increase, and then there is some leakage, and then because of more this capacity it will goes usually around 100 to 150 ml of CSF it will be produced, and then it will be circulating. Suppose if it is goes more than because of hyper pressure, means hyper blood pressure and all, no, it will goes more than this one. Again it will ICP it will goes more than 20 minutes. Again there is chances of getting ruptured, whatever it is, it will getting leaking. That is the thing. Whatever our subdural hemorrhage, even we can see that lateral ventricular burst, everything we can see because of this is the one. Even in case of 10% it will be because of this one CSF pressure, because of some tumors, some infiltratory infections and all. No, usually because of tumor formation in the lateral ventricles of the brain, it will produce more secretion. Because of this one also it will increases the ICP. This is the most thing we should remember. This all the three things we should. Usually most of the cases, no, EVD whatever it is, no, usually hydrocephalus, and then one more thing, injury to the skull. It is the most important factor. It will cause rise to ICP. This is the 0 to 15 is the 0 to 15 millimeter of mercury is the normal EVD pressure. See, an EVD system involves introducing a catheter into one of the ventricles of the brain. What I said you before, this is the one. It means it is introducing one small catheter inside the brain, and then with that they are draining excess of CSF. This is the thing. Then that usually this whatever EVD insertion, everything it will be done by the neurosurgery team, and then usually in OR, and then well equipped ER, and then well equipped ICU also they are doing. Main thing, neurosurgery team only they are going to insert this one EVD. A EVD system may be connected to a butterfly secured into a ventricular access device. This is the thing. Whatever usually there will be butterfly like this thing. Usually with the 2 or 3 stitches they are doing here in order to secure the tube. Again there is, see, this is the connection tube. This is the connecting tube, and then here we can see the 2 stop cock, and then this is the transducer. Everything what we are seeing, that is the one. Then usually I will tell you about the CPP. CPP means cerebral perfusion pressure. It means whatever our brain circulation, perfusion, everything. Perfusion means it's a recirculation. See, it all maintained by the CPP. CPP, cerebral pressure, perfusion pressure. And then suppose CPP, normal CPP is, it falls below, means it's in between the 70 to 100 mm of Hg. If CPP it comes less than 50 means it will cause brain ischemia or cerebral ischemia. It is most devastating, and then it is most worst condition. In this condition, no, brain means person will go to, if it is brain ischemia, usually you will go to brain dead like that thing, and all we should be aware about this one. If it is goes more than 100 means again it will cause somewhere hemorrhage, everything it will cause. That's why we need to keep this pressure in between 70 to 100 in order to maintain whatever are the homeostasis of the cerebrum. See, this is CPP is equal to means cerebrospinal cerebral perfusion pressure is equal to MAP minus ICP. MAP means mean arterial pressure, and ICP, as I said you before, means this cranium, whatever skull, no, around 80% it will come from the skull, and then from CSF around 10%, and then around blood around 10%. Suppose, see, if in this case you see here, see, I taken this one, MAP is around 85 mmHg, ICP is 10, it means 75 mmHg. In some cases, because of some tumor like this one thing in brain, because of this, means in the tumor like thing in ventricles, because of this CSF it will produce more. Because of this, if pressure is around 15 and then MAP is 85, it means even we have to consider this is the high thing. Because of this one and all, no, 15 it will be high, ICP is high, and then even because of this one CPP also high, like that they will think. Suppose if CPP is because of that lesion, whatever tumor in the brain, if it is goes more than 25, see, this is 25, here this is the 85, see, it will be around 110 mmHg. This is the most worst condition. If CPP goes more than 110 means it is the devastating condition. We should means immediately they should do the EVD insertion or hematoma. Means EVD insertion. If it is more means they have to do the means for hemorrhage and all thing and all, no, which they should insert the EVD, and then whatever hematoma occursion, everything they have to do. This is the thing, most devastating condition we should mind. See, because of in case of hypertension and all, no, because of hypertension, the MAP it will goes more than 110. Even CPP is 10 also. See, 110 it will be. Again, it is usually because of this one, because of MAP also, it is the one of the contributor for increasing ICP. That is the thing we should remind. Even we should maintain for all the that's why our doctors, they will say whoever from neurosurgery patients, any patient came means some means post operative thing and all, no, they will say to keep MAP in between 90 to 95. Because of this one, if it is cerebral perfusion, it is more than 110 means again it will increases the bleeding. Again, if it is less, if MAP is means CP, whatever our MAP is less than 65 means again it will deplete, means it will cause depletion of circulation inside the brain. Again it will cause the brain ischemia, whatever cerebral ischemia. That's why we need to keep. This is the thing. Again, see, this is the part of the EVD. See, this is the one. This is the patient part. See, this is the connected to this portion. What I said you before. This is this portion. This portion I'm saying. This is the this portion. You see, this is the portion. This is the patient portion. It's connected to transducer, and then this in this portion. No, usually we will this portion it will be connected to monitor. That is the one. This is the stopcock. Then this is the collection bag, whatever our drainage and all, no, it will be connected to here, and then whatever our drain collection, everything it will be collected here in this drainage bag. This is the laser level, means mercury level, in order to adjust the thing and all. Here this is, you see, you can see red thing, this is the mercury, whatever pressure and all. Then this is the collecting chamber, how early we need to collect, and then this is the supporter. See, this colors, it has different shadings and all. Usually everything, it's this setup, everything it will be done by the neurosurgery team. In case trained nursing staffs also, they can handle this one. Usually everything it will be done by the this one neurosurgery team. See, this is the brain. Then in case of increased brain and all, see what is the indications for means what is the common indication includes raised intracranial pressure. Means in which cases we can expect to see this one increased intracranial pressure. See, if patient has aneurysm, rupture, encephalitis, head injury, and then intraventricular hemorrhage, and then status epilepticus, and then subdural hematoma, cerebral edema, epidural hematoma, hydrocephalus, meningitis, stroke, tumor, and then head injury, and then cerebral or spinal tumors, acute hydrocephalus, everything we can see the increased raised ICP. Means ICP it goes more than 15. That is the thing. And then there is some contraindications for EVD insertion. Suppose patient has high this one PTT and INR value. Means any coagulation problems, or patient is receiving anticoagulotherapy. Suppose patient is receiving is an heparin infusion, or this one full anticoagulation therapy, means we are not supposed to go, because again if you are inserting, means again it will cause more bleeding. That is the thing. Then if patient has scalp infection, because we know this brain and all, no, it is the most this one thing, means most delicate thing. Suppose if minimal infection entered into this one, means it will cause most devastating changes, and then brain person will get, means that infection healing and all, no, it is very worst. That's why it will minimal means small infection also, it will cause most injury to the patients and all. That's why if patient has scalp infection and all, no, usually they are not going to insert this EVD catheter and all. Then see what is this is the nursing management I am saying. See, positioning, zeroing and securing the EVD. This is the thing. See how they are provisioning. See, here you can see how they are collecting this. This is the hourly they connected, and then this is the drainage collection bag, and then this transducer they are connected to monitor everything. See, this is the ICP. We can see everything is there. This is the digital one. What we are using. This is the one. Usually it will in 24 hours they will empty this bag. Usually this one hourly they are this tapka they are opening, and then they are releasing the clamp, and then everything it will be drying it here, everything. See, when we are positioning the patient, or when you are making zeroing and when you are securing, we should follow these things. When we are positioning or zeroing, check all connection and tubings are secure, and ensuring that move with the head. Suppose if you are turning the head or whatever positioning, means we should see the tubings for kinking or anything, and then we should take extra care. Suppose if it is accidentally comes out of EVD, it is most dangerous. That's why. And then if intubated and ventilated patient, means we should maintain head and elevation more than 30 degree in order to improve this one. Actually, this whatever that while doing the zeroing, see whatever this is the when we are keeping zero level, we should put one see here, it should be level, this drain chamber level, whatever this level now, it should be in the tragus of the ear. See whatever the tragus you can see here now. See this point, this in the tragus of the ear we need to calculate, means we need to keep like this, then only it will be, then only we can say the zero level. See here this is the zero level. I think because of this bag and all we can't see this one. See here, this is the zero level, they are facing the tragus level, they should do. Then establish correct zero reference point using visual landmarking tragus of the ear, and then ensuring that the chamber is at correct level and gauge prescribed by the neurosurgeon. This should be recorded in the physician notes as well as documented in the nurse's notes. See, this is the pressure, what pressure they are setting here. When CSF is means in this EVD, there is less drain output, means see from this EVD there is little means if it is decreased the output, means again doctors usually everything pressure adjusting everything, it will be done by the neurosurgeon doctor. It's must and should, it's mandatory, whatever increasing or decreasing the pressure, it should be done by the neurosurgeon. Suppose there is less means very little secretion and means output and drain output, usually they will increase the pressure. Suppose more output, means if hourly it is producing more than 30 ml 40 ml of this one, means this is a CSF marks, it's draining, means usually they will decrease the pressure, like the thing. Usually that normal pressure for setting this one, see here, see they kept around 3 the level. See, you can see because of more output you can see this one, that's why they kept very minimal pressure like that. Usually 5 to 15 is the normal pressure, within this range only they are keeping the pressure. See, usually whatever when we are doing this one and all, gauging and all, when we are taking endorsement and all, we should see this one what they give means how much level they fixed, and then whether in the physician notes what they written, everything we should document. That is the thing. Then when we are taking endorsement, we should check that patient has valid EVD order, then height up the value, whatever the gauge, everything, it will be in which pressure it is there, see which height, and then units, and then reference point, tragus level, then drainage, how it is going, everything we should take care. Means we should take from the whatever our that endorsing this one stop and all. Then reportable limits are noted and adhere which patient is specific. Suppose if EVD output is less, means immediately we need to reassess, we need to recheck all the tubings, and then we need to take immediate actions. Then EVD drainage point is set at the prescribed level. Means what I'm said, that whatever this pressure level, it should be in the whatever in physician notes what they written now, it should be there. We need to check that one. Then the EVD transducer is there. Now what I said this one, it should be in the 0 level. Means it should be in the this one ear tragus level. See, you can see this is the thing. This is the thing. Again, if it is increasing, means again it will not, means that whatever cerebral perfusion, no, it will not happen correctly. That is the thing. See, you can see EVD like this, means nicely it will come. There is no obstruction. That is the thing, reason behind. And then EVD column is auscultating, and patient head dressing is dry and intact. Whenever seeing this one dressing and all, it should be intact, and then it should be clean and sterile. That is the thing. And then report any signs of changes in patient's neurological condition to the medical. Suppose a patient has suddenly patient dropped GCS and then he became unconscious, everything we need to inform. Then this is the thing, how this is sterile thing, how they are touching, everything we need to do. This is the thing. We are not supposed to touch this part in bare hand. And then the TVG drain output, no, we should monitor hourly, and then we should follow TBI chart. This one total brain injury chart, no, whatever thing and all we should monitor. Then drain status we need to check. Means hourly we need to document what is the drain status. Means whether it is clamped or opened, and then what is the level after this one EVD. Then what is the this one height, means in which level, whether level is 10, whether level is 8, we need to check. Then hourly output, and then CSF appearance. See, in this little bit mild reddish, I think between everything we need to red, and then it's like a thick thing, no, we need to inform whatever the color changes, everything we need to inform. Then whether drain is oscillating. See, oscillating. See, here you can see there is some movement, it will be there, some moving bubbling movement will be there now. That is the thing we should see. Then patient position, everything we should do. Whenever if we are doing patient supine, means you must do the EVD clamping. Otherwise, no, again it will cause, means because of more draining and all, no, it will cause some deviation. That's the thing. Then what is the conscious level? Say patient is alert, crying, seated, everything we need to assess. And then we should see the dressing status, whether it is clean, intact, everything we need to see. And then if there is any oozing or foul smelling or pus collection, anything, means we need to inform the primary team or our ICU team, like that. We should take dressing interventions. So this EVD has some of the complications. What is the complications? And then because of EVD, patient will get fever, redness, or exudate at the site. Suppose because of whatever prolonged days, and then unhygienic handling, everything, no, it will cause some infection. We know, I think if patient has some, they will do the CSF culture. Often they will do the CSF culture if they noted any growth and all, no. Usually if they are going to start meropenem, everything. And then in some cases of MD or something and all, cholesterol also they will start, whatever. This is the thing. Infection management. Infection is the one of the complication of the EVD. Then because of some less output in advenic drainage and all, no, and then tube block will be hampered, and then suppose sometimes unknowingly if clamped also, it will block the drain. That is the thing. It is also one of the complication of the EVD. Excess drainage because of increased this one pressure and all, if there is more drain output means can lead to collapsed ventricles, and then subdural hemorrhage, and in some cases upward herniation because of more draining means because of this one herning lateral ventricles. No, it will getting twisted like this thing, like this. You can see like this twisted things, and I'll see you can see that malpositioning, see in this ventricle because of this one excess drainage, and I'll see you can see this subdural hemorrhage, everything you can see this. You can see this tube is here, and then this one it's out. In this you can see this tube actually it should be here, but see it's come out. See here you can see that abnormality, whatever the thing, and I'll see here there is small interventricular hemorrhage, everything, it all the complications of EVD. See here you can see there is this is the properly positioned EVD, how it is draining everything. See, this is the thing because of this EVD over excess drainage and all, it's caused some this one. This is the thing. Then because of continuous we are removing, actually what is the CSF means cerebrus means the CSF. No, what it will do, it gives whatever, it maintains our brain circulation, and then it provides feed to brain. That is in simple meaning. CSF is the thing, it will feeds to brain. Suppose everything, some sodium, everything it will be there, sodium, potassium, glucose, around 65% of the our this one sugar, it will be consumed by the this one CSF. That is the thing. Suppose when we are doing the TLP in whatever that EVD sampling and all, no, usually along with this we will send this one blood sample, as a blood sample means blood glucose also. Even if you are doing LP also, it means lumbar puncture also, means on that time usually that our doctors they will say to check one's RBS. This is the thing, they want to correlate what is the thing, and all means because of this one CSF again we are draining the excess this one and all amount and all, no, there will be chances of getting sodium and potassium loss. That's why in order to this is also one of the complication of the CVD, fluid and electrolyte loss. Then CSF leak, and then suppose if drain is came out, see you can see because of this one drain is accidentally, if it is came out or something, see you can see it's came out from here. In these cases, no, again it will cause infection. That is the thing. Again accidental removal of EVD, accidental removal of EVD, CSF leak, fluid and electrolyte loss, excess drainage, black drain, then infection. These are the main complications of the EVD, whatever it is thing, this one and all. Then next we'll go to nursing interventions. What are the nursing interventions we have to take? Hourly we should monitor the vital signs, GCS, intake output chart. Then CSF drainage out moments, that CSF drainage output and all, no, hourly we should maintain. Then patient watch for signs of increased ICP or loss of consciousness, we should monitor. Then frequently we should check EVD, any kinking, any blockage, anything is there means immediately we should inform to our intensive neurosurgeon. Then whenever we are doing transportation, while changing the position, and then when we are making patient supine, everything we should means on that time we should make EVD, it should be clamped status. Means see, we should see this is the one, we should make it, we should turn like this, and then we should make it we should keep this one as a clamped status. This is the one. Then while handling with the EVD circuit, and all, we should maintain sterile technique and all. Then we should do hand hygiene and hand washing. Then usually EVD sampling, everything it should be done by the neurosurgeon, and then in few hospital trained nurses also doing, but most of the hospitals and all, no, neurosurgeon they should do. And then see, unknowingly we are not supposed to inject anything into this. Suppose this is, we are not supposed to inject anything. Even doctors also they told means at everything, because we don't know that what is the pressure, everything, how we need to give everything, they should be done by the doctors. Okay. Then this is the another thing, hourly CSF drain output morning. Suppose if first hour there is no output means we should check the tube and then inform immediately to the neurosurgery team. then they will check the tube, means that tube again they will try to adjust with the pressure. Suppose still if it is not doing, means again they will go for CT brain in order to look that positioning of the EVD. And I'll see the nurses how the sterile, and there she's cleaning everything she's doing. Then level of EVD should be adjusted by the neurosurgeon. What I said you before, it should be whatever the level in this level, it should be adjusted by the neurosurgeon. And then we should clean, we should have, there is a written order, physician order for that. This is the thing, when they are adjusting the pressure, means we should get one order for that. And then we should follow TBA chart, TBA total brain injury chart, means it includes all sodium level and then HB, everything we should take care. Then patient and family education, whenever patient is in this one EVD insertion and all, no, we should support the family. We should explain the what is the scenario, what is happening, why this EVD insertion is required, everything we need to inform to the family. And then because of this one, they will get a little bit hope, and then it will improve the whatever self confidence of the patient. That's why we should give proper patient and family education. And then this is the EVD, whatever this is the thing, and this is the one. We'll see. I think a little bit you got little bit information regarding the this one EVD and all. We'll conclude this one. Thank you for everyone. Thank you for seeing this video. If any doubt means, please ping one comment. We will discuss that one. Okay. Thank you so much for. Thank you all. Thank you so much for watching this video, and thank you.